Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the December 2025 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'm going to provide a brief overview of key manuscripts published in each of our content areas. We'll start with our asthma section. The inhaled corticosteroid dose-response relationship when administered as an ICS-LABA in maintenance combination is uncertain. In this issue, Noble and colleagues report findings from a systematic review with meta-analysis designed to answer the question, what is the inhaled corticosteroid dose response of maintenance ICS-LABA therapy? 12 randomized controlled trials with over 6,300 participants were identified. High dose versus medium dose ICS-LABA was found to reduce the odds of a severe exacerbation with an odds ratio of 0.81. There were no other clinically important differences in efficacy or safety outcomes of high dose versus medium dose ICS-LABA, and no difference in all outcomes comparing high dose with low dose or medium dose with low dose ICS-LABA, though these evaluations were limited by the number of identified studies. These findings show that maintenance high-dose ICS-LABA reduces the odds of a severe exacerbation compared to medium-dose ICS-LABA, particularly in patients with a high risk of exacerbation. Our chest infections content area is next. COPD, asthma, bronchiectasis, and cystic fibrosis are characterized by inflammation and mucociliary dysfunction. In this issue, Kant and colleagues explore whether there is a relationship between inflammation and mucociliary clearance in chronic respiratory conditions to determine if biology could stratify patients into therapeutically relevant subtypes. Sputum cytokines, neutrophil elastase, dry weight, mucins, and rheology were significantly different between disease groups and control participants. Two clusters were identified, defined by neutrophilic or T helper type 2 inflammation. The Th2 cluster had lower sputum dry weight and DNA content and higher mucin 5b. The neutrophilic cluster had higher viscous to elastic ratio, decreased alpha diversity, and increased presence of proteobacteria. More neutrophilic inflammation was present in cystic fibrosis and bronchiectasis. Both clusters were present in all disease groups. These findings show patients with airway disease cluster according to inflammatory endotype, so that assessment based on disease label may be aided by endotyping of the sputum. Our COPD section is next. Simplifying the spirometry protocol may increase the feasibility of COPD screening in community settings. In this issue, Wu and colleagues report findings from a community-based cross-sectional diagnostic study designed to determine the diagnostic accuracy and time efficiency of a simplified spirometry protocol in screening for COPD. Simplified spirometry required only one acceptable maneuver. 619 screen participants were analyzed. The area under the curve of the pre-bronchodilator simplified spirometry was 0.972, with a positive predictive value of 77.4% and negative predictive value of 98.1%. Sensitivity was 96.6% and specificity 86% for identifying spirometric COPD. The average exam time was 2.8 minutes, as opposed to 32.1 minutes for routine spirometry. These findings suggest that pre-bronchodilator simplified spirometry could have usable accuracy in community settings with significantly reduced exam times. Completing this section is an original research article that explores lung function decline and airflow limitation risk in PRISM subtypes by smoking status. Next is our critical care content area. Specialty palliative care consultation may mitigate persistent critical illness development by influencing the transition to comfort-directed care when appropriate. In this issue, Viglianti and colleagues report findings from a retrospective cohort of VA ICUs designed to determine if hospitals with the lowest rates of persistent critical illness have higher use of specialty palliative care consultations during the first 3 days of admission to the ICU. They included over 370,000 ICU hospitalizations from 104 VA hospitals, where 5.4% experienced persistent critical illness and 4.8% underwent an early specialty palliative care consultation. Development of persistent critical illness ranged from 1.4% in the lowest quintile hospitals to 5.4% in the highest quintile hospitals. The incidence of early specialty palliative care consultation was not correlated with the hospital level probability of persistent critical illness, with 5.3% in the highest quintile and 5.8% in the lowest quintile. These findings suggest that cross-hospital differences in persistent critical illness development are not explained by differential use of early palliative care consultations, and that other care factors should be assessed. Other original research published in this section includes a multimodal study of investigators, coordinators, surrogates, and patients that evaluates the performance of the surrogate-informed consent process for critical care research, and a sister article on approaches for establishing trust and alleviating stress during the surrogate-informed consent process. Completing this section is a chest review on sepsis-induced cardiomyopathy. On to our diffuse lung disease section. Patient perspectives on illness uncertainty and sarcoidosis have not been evaluated critically. In this issue, Matthias and colleagues report findings from semi-structured qualitative interviews with patients who had biopsy-proven pulmonary sarcoidosis and were receiving treatment for the disease. The interviews were designed to determine how patients with sarcoidosis describe their lived experiences with the disease and challenges they face in receiving care. The impact of illness uncertainty was a shared component of the 25 participants' care journeys. Key themes included the burden of limited disease awareness, uncertainty about sarcoidosis management, and the unpredictability of disease progression. Uncertainty contributed to delays in care, poor disease control, and psychological distress. These findings highlight the impact of patient illness uncertainty on sarcoidosis disease outcomes and psychological distress. Completing this section is an original research article that evaluates the lymphocyte proliferation test in the differential diagnosis of sarcoidosis and chronic beryllium disease. Next is our education and clinical practice content area. Generative AI tools could streamline multiple choice question creation. The quality of AI-generated multiple choice questions remains unclear. In this issue, Safadi and colleagues with the Critical Care Education Research Consortium had 31 faculty experts evaluate both AI-generated and human expert-created questions to determine their alignment with learning objectives, accuracy of the chosen answer, clarity of the STEM, plausibility of the distractors, and difficulty level. They found that AI-generated multiple-choice questions were statistically non-inferior to expert-written questions. The faculty experts were unable to reliably differentiate AI-generated from human expert-written questions. These findings suggest that AI-generated multiple-choice questions using ChatGPT 01 are comparable in quality to those written by human experts and could serve as an efficient and scalable alternative for medical education assessment. Also in this section is an original research article that explores clustering chronic cough patients using reported sensations and triggers in the topic questionnaire, a research letter about efforts to enhance participation in the NIOSH-B reader program, and a How I Do It review on delivering a regional procedural boot camp for incoming pulmonary and critical care medicine fellows. Our pulmonary vascular content area is next. The impact of cardiovascular risk factors on the right ventricle pulmonary circulation unit remains unclear. In this issue, DeLuca and colleagues report findings from 362 patients with at least one cardiovascular risk factor, but no overt cardiovascular disease, who were included in the Right Heart International Network Registry, as well as 375 controls, all of whom had resting and exercise echocardiographic evaluations. The study was designed to determine if there are differences in resting and exercise RV function in patients with cardiovascular risk factors, but without overt cardiovascular disease when compared to healthy controls. Cardiovascular risk factor patients had lower TAPSE to systolic pulmonary arterial pressure and a steeper mean pulmonary arterial pressure to cardiac output slope compared to controls. Cardiovascular risk factor patients also had worse exercise capacity with chronotropic incompetence. The presence of cardiovascular risk factors affected the combined outcome of all-cause mortality and hospitalization. These findings identified factors relevant to exercise capacity, RV-PA uncoupling at rest and during exercise, along with elevated dynamic PVR in patients with cardiovascular risk factors. Completing this section is a chest review on post-treatment monitoring of pulmonary arteriovenous malformations. Next is our sleep content area. The apnea-hypopnea index has limitations in reflecting disease severity. In this issue, Paker and colleagues report findings from a secondary analysis of 368 adults with obstructive sleep apnea from the randomized intervention with CPAP in coronary artery disease and sleep apnea observational cohort. The study was designed to determine if high hypoxic burden more strongly associates with major cardiovascular and cerebrovascular adverse events than an apnea-hypopnea index of greater than 30 events per hour. High hypoxic burden was associated with major cardiovascular and cerebrovascular events, the hazard ratio of 1.87, particularly among untreated or non-adherent patients and those with baseline excessive daytime sleepiness. An AHI of greater than 30 was not associated significantly with major cardiovascular and cerebrovascular adverse events. A high apnea-hypopnea index with low hypoxic burden was also not associated with major events. These findings suggest elevated risk of major cardiovascular and cerebrovascular adverse events in adults with moderate to severe obstructive sleep apnea is driven more by high hypoxic burden than by the AHI. Completing this section is a How I Do It review on transitioning between volume-assured pressure support modalities on home mechanical ventilators for chronic respiratory failure. Next is our thoracic oncology content area. Whether segmentectomy is associated with similar oncologic outcomes to lobectomy for patients with node-negative T1C tumors, that is, those 2 to 3 centimeters in diameter, remains unknown. In this issue, Matthew Andrews and colleagues evaluate over 12,800 patients from the National Cancer Database to determine if the survival of patients undergoing segmentectomy versus those undergoing lobectomy differ in this group. 526, or 4.1%, underwent segmentectomy. No difference was found in overall survival among patients undergoing segmentectomy versus those undergoing lobectomy in multivariable adjusted analysis, an adjusted hazard ratio of 1.13, or in propensity score matched analysis, with 5-year survivals of 70.1 versus 72.0%, respectively. The findings were similar in the subset of over 8,500 patients with pathologic T1C N0M0 disease. These findings suggest that there would be value in future prospective studies comparing lobectomy and sublobar resection in patients with T1C N0M0 tumors. Also in this section is a retrospective cohort study evaluating the incidence and diagnostic patterns of discordant pleural fluid exudates, an evaluation of the distribution of KRAS mutation status across occupational categories in non-small cell lung cancer, and a research letter that compares multiple strategies to assess CT lesion location within the lung. I encourage you to read our commentary series, where you'll find a piece on the VA vision of advanced practice respiratory therapists, another on central venous catheter care and CLABSI risk reduction, and a concise guide to inverse probability of treatment weighting for leveraging observational data for causal inference, as well as our humanities series, where you'll find an original research article on the influence of hospital policies on clinicians' decisions to withhold or withdraw life-sustaining treatment, and an exhalations piece titled The Other Side. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope that you enjoy the December issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.